Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
Everyone, I'm Andre, nice to meet you, lovely to see you. Welcome to the Woodland, welcome to this first CAMS Campfire session of 2022. We've had a long winter break, but we're back, and this time with added tweeting, you'll be glad to hear. My colleague Catherine Saunders is on Twitter this evening, and she is live tweeting this event. The hashtag is CAMS Campfire. Do get involved in that live if you want. Share your thoughts on Twitter, and also afterwards. I'm sure the conversation will carry on a bit like Eurovision into the early hours of the morning after this session. So we're talking today about technology delivered cognitive behavioural therapy for pediatric anxiety disorders. That's the title of the paper that we're looking at. So basically digital CBT for young people with anxiety. And you know, you would have to be living in a hole in the woodland with no internet connection to have missed the fact that there's a big problem out there with youth mental illness. There's a big problem with inaccessible services, a lot of young people not getting the support they need. Just this weekend here in the UK, we had a report published which was widely covered in the Sunday newspapers, which showed a 50% rise in the last 2 years of young people using mental health services. 420,000 children in England every month using mental health services. So really frightening figures. And of course, a lot of young people can't access the care they need, or they have to wait a long time for the care they need. So perhaps what we're going to talk about today is part of the solution to that. This kind of online help and support may help reduce those waiting times. But I guess we need to work out what works best and for whom. So that's a key part of our discussion this evening. Please do introduce yourselves in the chat. It's lovely to see so many people having done that already. Do carry on. Make sure you choose everyone when you post your message in the chat. Otherwise, it would just be us panelists who can see it. It'd be great for everyone in the chat to see what you say. And please also just complete this poll. So it's probably popped up on your screen. Tell us what your primary role is in this event. Obviously, we all have dual or triple or quadruple roles, but tell us your primary role for being here in this event, so we can get a sense of who we've got in the audience. I think we had about 500 people register for this event, so we'll probably have a couple of hundred people here over the next hour or so. Okay, so that's nice. We've got the usual really broad mix of people. Looks like the biggest professional group that we've got here this evening are educational professionals, 24%. We've got lots of therapists and psychologists and psychiatrists, CAMS practitioners, also a fair few researchers and students, and some patients and carers and some others as well. So yes, lovely to see such a mixed group of you here this evening. Thanks very much for doing that. So I'm just going to briefly introduce you to everyone you can see on your screen at the moment, and then we're going to get into the conversation. Matti is here tonight. That's Dr. Matti Cervin. He's a senior clinical psychologist from Lund University in Sweden. Welcome, Matti. Lovely to have you here this evening.
Thank you. Lovely to be here.
And Matti's paper is the one that we're going to be looking at during the session today. That's available on the ACAM website. We will share the links as we go along. Maria is here as well. Welcome, Maria. This is Dr. Maria Lodes. She's a clinical psychologist, a lecturer and a researcher at Bath University here in the UK. Lovely to see you as well, Maria.
Hi there, nice to see you.
And we also have Yasmin with us this evening, who's a peer researcher currently based at Warwick Medical School here in the UK. Thanks very much, Yasmin. Lovely to have you joining us as well.
Hi, happy to be here.
And you will, if you've been to one of these campfires before, you will know Elizabeth and Douglas, my colleagues in the campfire team who are here also. Elizabeth is in charge of the chat. She'll be moderating that and helping us get the questions that you guys ask and put them to our panel later on. And Douglas is our critical appraisal black belt, and he is going to be looking at Matti's paper and doing some nice ninja moves as he does so. So let's get into this. I'm going to open up with some broad questions about this area, and then we're going to get into the detail of the paper, and we're going to think about implications. So first of all, Maria, I wanted to ask you, just broadly, I suppose, thinking about telehealth interventions for mental health. I suppose one of the issues that we have in this area is that there's so many different names for this stuff, you know, computerized CBT, internet-based CBT. I think we call it technology-delivered CBT with this paper. I guess all of this digital stuff, websites, apps, mobile phones, telephone support, text messaging. Can you paint a picture for us of this broad field and what kind of stuff is available for young people in this digital space and what the kind of variation is? Give us your sense of that.
Yeah, I think you've hit on the key point here, Andre, which is that there is so much variation in what things are called and in what's available. There are so many different ways in which tech can be used to support or deliver therapy. We've seen that in the pandemic. It can just be a way to have conversations that can't be had in the room because of COVID. It can be a way that therapy is entirely delivered without any therapist input or anything in between. And I think that is a real challenge, because when we're talking about this, we have to be really clear on which kind of input we're talking about. But there are lots and lots of ways in which tech can be useful to help young people with mental health problems at different stages of their journey through recovery. And there are so many innovations that keep coming up. I think broadly speaking, we're thinking about kind of internet delivered and mobile app delivered approaches with or without therapist input, but there are so many different variations, and I think we've yet to see the full capacity of that being you know, kind of capitalized on as we go forward.
And this with or without professional involvement, guided or unguided, they're sometimes called, aren't they, these interventions? So sometimes they might be guided by a therapist. Sometimes they might be part of, you might have in-person therapy, and then you might have some lessons to do during the week before you go and see a therapist again face to face. I guess that's quite a different thing, isn't it? So you might have an online CBT intervention, which is a completely computerized sort of chatbot style thing, or you might have an intervention which is with a therapist and with some digital stuff. Those are very different types of things.
Absolutely.
Have we got a sense of, when we do a big review, Matti, maybe this is a question for you, when we do a big review of this sort, where we're looking at all the different research over many years, and we're bringing this all together, of how much of it is the guided, nice, holistic stuff, and how much is the rough and ready, unguided stuff?
Yeah, there is a lot of heterogeneity in the studies we looked at, because they stretched a period of 15 years. So 15 years ago, computers were quite different, and the internet was different, the capacity. So these 9 studies we identified, stretched from kind of computer games in the 15 years ago to nowadays the more, what we believe is, we often in Sweden call it internet delivered CBT. So it's like chapters or modules online, and then you have like chat with your therapist. So it stretches all of that. And with regard to therapist involvement, we tried to look at that, but it was quite hard to code, because it was very different across the different studies. And some treatments used like in-person sessions, a few of them mixed within. And we found some evidence that more therapist involvement seemed to be related to better response rates across studies. But because we have so few studies, must be very, it's limited what we can say. So I think it's hard to really say anything really clear about the literature at the moment. And also because in children and adolescents. So we're not only stretching 15 years of computer development, we're also trying to treat a heterogeneous group of disorders, anxiety disorders, that can stretch from phobias to social anxiety disorder, and in kids that can be 7 years of age or 17. So it's quite a lot of diversity involved in the field.
Yeah, I think it's an important point to make, isn't it, that these sorts of interventions are very much part of standard care now. It's not like we're saying we're going to try and replace, you know, face-to-face in-person therapy with digital, which will be, you know, automated, getting treated by a robot. And I think that's often the perception in the public. You know, I don't want a digital intervention. I want to go and see a human being to talk to about my problems. And it's sometimes, I think, also the perception amongst health professionals that digital is seen as a cost-cutting way of replacing them. I often get that response on Twitter when I blog about new research, which is internet delivered. So we can maybe come on to that a little bit more as we go on. Yasmin, I wanted to bring you in here now and you just, you know, to share your own thoughts about digital help and support for youth mental health. And I suppose your sense of what young people feel about this kind of support. Yeah, over to you.
Yeah, I think with digital support, I think there's a feeling amongst young people that they're kind of provided with digital CBT as kind of being brushed off, or because there isn't enough time, or like the waiting list is too long. So they're often recommended digital methods like digital CBT for anxiety, which might not be the case with people who are older as often. So I've had both face-to-face sessions of CBT, and I had digital CBT as well. And I had definitely found, speaking to other people my age as well, that it really came down to like the severity of the condition, of whether they found it helpful or not. So I think it really depends on the person, on how severe their mental health issues are. So when my anxiety was at its worst, I don't think having a digital help would have really been appropriate for me. But I think more young people are like referred on to digital methods.
Yeah, that's a really interesting point, isn't it? I suppose there's this sense that young people will get the digital stuff more than older people. Mm-hmm. Let's give it to the young people. They like digital stuff, don't they? They're always on their phones. And of course, that's not always the case. It's much more complicated than that. I think your point about severity and where you are in your kind of illness journey, for want of a better cliche, is really key, isn't it? Because I suppose digital interventions, if we're thinking about them as universal, preventative, population level interventions, then we should be bringing those in as early as possible, shouldn't we?
Yeah.
Before illness gets too severe. Yeah, that's really interesting. So I wonder if we could think a little bit more, Matti, about what kinds of interventions there are around now. You said, you know, there's lots of different stuff, and over the last few years, it's developed a lot. Can you kind of summarize computerized CBT, or whatever we want to call it, in terms of its effectiveness and its safety? What do we know?
I would say based on this review, we can say that technology delivered CBT, whatever it is, seems to be more effective than no treatment. That is waitlist or treatment as usual. That I think is equal in UK and Sweden, that treatment as usual is often waitlist or waiting for other things to happen. So I think based on this review, we find quite strong evidence that if we measure outcome as meeting criteria for an anxiety disorder, then technology delivered CBT was clearly better than being on a wait list or having treatment as usual, or even having a psychological placebo treatment, like just stress management, for example.
And what about the wider literature? What would you say in general we can say about digital CBT for youth mental health?
I know mostly about like internalizing difficulties, depression and anxiety. And I would say I was also asked by the Swedish government to do a review about technology delivered CBT for depression in youth, but we couldn't find enough studies to do it. So I would say that there is great uncertainty about the efficacy, the effectiveness, and the safety of these interventions actually. Because we have few studies, and most of the studies have recruited participants from like social media. So we don't really know how these interventions work within CAMS, Child and Mental Health Services. And as we also found in this review, there were many patients or participants that were not in remission, that had not responded very greatly to the intervention. So they were in need of more treatment. And that was the question in my head, like writing this review, how can we make certain that they get what they need after this first intervention? Is there a risk that we might lose them if we do it more online and without so much therapist involvement? So that was kind of a safety issue for me. So how to integrate these kind of interventions into the broader care pathway in a safe way.
Safety is really important, isn't it? If we're thinking about this as a universal intervention that we roll out for people, have you got a sense of how much of the current evidence measures and reports on safety of interventions?
In this review, not much. So adverse events has really been lacking behind in psychological treatments. In the medical literature, they are very used to reporting adverse events and side effects. But within the psychological literature, we have kind of lived in this belief that psychological treatment or therapy is very non-harmful. But now we know that some people experience harmful effects of psychological treatment. And I think one of 9 studies reported adverse events. So that is just within the treatment. But then, of course, we have other safety issues of a treatment within a care pathway. So if we give a treatment to young people, like Jasmine said, like maybe a young person feels I'm not being listened to, then we might risk that person not reaching out for help anymore. So that is also a risk with the treatment. Like if you offer treatment that young people not really want, then you have a broader risk that maybe the healthcare seeking behaviors are affected, etc.
Yeah, absolutely. Maria, can you say a bit more about how these digital interventions compare to in-person interventions? So I suppose there's this sense that obviously in-person is best and digital is a sort of poor replacement, and if I have to do digital, then that's what I'll do. But is that really the case, or is it more complex than that?
I think it is more complex than that, Andre, but it's really interesting. We've done some qualitative work with young people around their experience of face-to-face versus digital, and they do say that you get a different sense of connection with a therapist when you are doing digital. That's not to say it's worse, but it's different, and that might be useful for different young people at different times. And I think it's always important that there are options. Some young people might prefer digital, others might prefer face-to-face. But I'm fundamentally not sure that for the current generation of young people, that there is this division that we see between either it's one or the other. I think the way they live their lives, technology is just part of life. It's tools. And, I think maybe we need to flex our thinking too around whether it is either digital or face-to-face. But to answer your first question you posed to me, Andre, in terms of the real differences, I guess digital delivery fundamentally probably means at the moment because of the capacities of technology, and I'm aware this is rapidly developing, but that digital delivery is less flexible and less personalized than what we see if someone comes to see a face-to-face therapist. You know, if someone comes to see Matti or myself as a clinical psychologist, we can deliver really bespoke, individualized CBT that's really tailored to them and to their interests, their examples, their narratives, their language. And at the moment, although we have some degree of personalization built into anything that has a digital string to it, it's still limited by how much it can personalize. As I say, I know with really clever algorithms, we're going to really improve this, but ultimately it's never going to be the same as a responsive human being in the room. And although young people do seem to experience a therapeutic alliance from a digital platform, it isn't the same as the connection you get in the room.
So I'm going to take issue with that because I think it is sometimes better. Yasmin, what do you think? When is digital better than in person for young people with anxiety?
For people with anxiety, I think digital is better when they're really struggling to have that face-to-face interaction. So I think definitely digital would be better for that. But I think you only really understand by speaking to that young person and understanding their needs. Also, I think digital is better for young people as well with anxiety as well, who might not feel comfortable speaking about the issues face to face, especially when you have anxiety. That can be really difficult, like with eye contact and speaking about really intimate things. That can be really difficult for young people. So I think digital is better because it does provide kind of a barrier, but it's kind of beneficial. Because sometimes when I had a CBT, I did feel slightly more comfortable, like writing things down. It just felt like I could be more open. So I think it is good for people with anxiety who might not feel comfortable speaking about things in person.
Yeah, absolutely. Okay, we're slightly overrunning for this bit, so I'm going to draw it to a close. We're going to listen to Douglas's video in a second, but before we do that, I just want to start our second poll, which is asking whether you have tried online CBT. I know I have. I won't tell you what I thought of it, but tell us if you have tried online CBT either as a service user or as a therapist, and maybe that you tried both, in which case just choose the one that you fancy. And we're going to be moving on after this to Douglas's critical appraisal session, where he's going to tell us what he thinks of Matti's excellent review. Oh, sorry, Douglas, I'm stealing your thunder. So, well, that's interesting. So actually only 14% of people have tried online CBT as a service user, only 21% as a therapist. So the vast majority of you, 2/3 of you, have not. And maybe that's why you're here today, to learn a bit more about it. But that's a very interesting, I'm quite surprised by that. Maria, are you surprised by those numbers?
Yeah, absolutely. And hugely excited by them too. It's so great to know that we've got so many people who are interested from such a range of backgrounds. So yeah, very helpful.
Yeah, brilliant. Okay, so over to you, Douglas. Let's hear what you thought of this paper.
Thanks very much. A brilliant, fascinating conversation. It's obviously a very nuanced issue, and you know, this feels like another tool in our box. But healthcare has a bit of a history, I suppose, of over enthusiastically rushing to adopt new things, but and perhaps getting ahead of the evidence. So here's a quick video are recorded that you can watch separately later if you want, that runs us through my appraisal of the paper. Hi, in this short video we're going to talk about some of the things you should look for in reading a systematic review and run through that process very briefly in the context of this paper on technology-delivered cognitive behavioural therapy for pediatric anxiety disorders. So we're going to run through a series of questions which are a useful framework that you can use when you're reading any systematic review. The first and most important question is, what were they looking at? What is the question of the review? This should be clearly focused on patients' interventions and outcomes. We need to ask, did they look for the right types of studies? So the studies that address those questions with the right method. And we would ideally like to see the protocol for the review published in advance. So we can't do any of the outcome switching or selective reporting. We need to be assured that the reviewers found everything, that they didn't miss any studies, as we saw at the start. And we need to make sure they only included stuff that's high quality. So the GIGO principle there of garbage in, garbage out can apply. So if the underlying studies are biased, then the review is likely to be biased. And finally, the all-important question, does it make sense to combine all these different studies into one estimate? Helpfully, there's a checklist produced by the Critical Appraisal Skills Programme that you can run through to help to guide your thinking when you're appraising a systematic review. And these are the questions we'll be answering today. So what did they do in this study? Well, our first step is to look at the question. And here we've pulled out the key features of the participants, young people less than 18 years of age, that meet the criteria for any anxiety disorder on a structured diagnostic interview. So that's quite a clear and specific definition of that population group. We might talk about different ages and things like that, different aspects of the population, but that gives us quite a clear starting point. The interventions, it's maybe slightly harder to be exactly sure what's going on, but what we looked at here was cognitive behavioural therapy delivered primarily by digital means via an internet app, cell phone, tablet or computer. There could have been different amounts of therapist involvement or caregiver involvement in those programs. So there was lots of different programs, but they were all under this heading of TCBT. We also looked at different comparisons, studies with slightly different comparisons. Some of them gave the control group treatment as usual, some of them put them on a waiting list, and some even had a psychological placebo intervention. So that's what TBC was being compared with: treatment as usual, waiting list, or a placebo. And in this case, the reviewers focused on primary outcome of remission of the anxiety disorder. Again, defined by diagnostic interview, so that's quite good, using the same sort of method before and after. And the outcome was measured immediately after the treatment course was completed. So a key question, of course, is what do we mean by TCBT? And TCBT is actually a new acronym on me. This type of CBT has been described in lots of different ways in the literature. And you can see from this wall of words, which is taken from the literature search the reviewers did, they worked pretty hard to make sure all the possible ways of describing that intervention were included in their search. So that gives them a good chance of finding all of the published material that's relevant to our question. We're also looking at the review. We've got a pretty clear flowchart of everything that they did as they went through their search, which records were included and excluded, and some of the reasons why certain papers weren't included. So we ended up with 9 studies with around 700 patients to work with. And that's quite a small number, given that we're looking at all of the studies that might have been done. But I think in this case, that's probably because we've got that very specific focus on people with a diagnosed anxiety disorder. We also need to think about the quality of the studies that they included. and how they went about finding and including the studies in their review. So one of the key features we look for here is that you have two different people making those decisions, because one person might have some bias in themselves. It can be a tricky decision to decide whether to include a study or not, and what its quality rating should be. So one of the good things about this review is that we can see that two different reviewers carried out these tasks and then they compared the results. So that's what you might think of as blind independent reviewing, and they used a consensus method to resolve any disagreements. So that gives us the best chance of having a reliable evaluation of what's relevant to include and what the methodological quality is of the stuff we're including. And so, very quickly running through that checklist, here's how I evaluated the study. One of the key things to talk about, we've already mentioned the different types of intervention, but another issue was with the way this systematic review was done. It was commissioned based on the PICO being defined, in this case, by the Swedish government. So it wasn't like other academic systematic reviews, which start off with the protocol and then run through that process. If you like, the protocol was defined through an invitation to tender, if you like, from the Swedish government, who wanted to find an answer to this question. So it's kind of that's why I put this. I'm not quite sure about that question at the start of the checklist. But otherwise, we had quite clearly defined patient populations and outcomes. The authors looked for the right type of papers. They looked for randomized trials relevant to the question. They worked quite hard to make sure they found all of the published evidence in the databases that they searched. And as we've seen, they did quite a rigorous assessment of the quality of the evidence that was included. We still do, I think, have a little bit of a question mark as to whether it makes sense to combine the studies. They found some evidence of heterogeneity in the results, and also, as we've discussed, what actually is the CBT intervention is quite hard to tell from research. It's not the reviewer's fault, it's because of the way that we write up these kinds of studies. It's quite hard to tell sometimes what exactly went on. So a quick look at the overall result, though, shows quite promising findings. The studies that looked at the primary anxiety disorder outcome were quite consistently finding in favour of TCBT, although there's quite a wide range there in what that overall effect might be. But the odds ratio of 4.73, that's roughly speaking, people who received the CBT were around 4 to 5 times more likely to achieve remission at the end of the treatment compared to the ones who were in the control group. So it looks like there's some sort of effect happening here. Another just kind of little question mark to raise is we can see from the funnel plots that presented here a little bit of asymmetry. So the studies are slightly unevenly distributed around this overall finding of 4.73. That might suggest there could be publication bias, so there could be some studies that have been done but not been published. So are these results important? Well, I think they probably are. I don't think that there's results that we can ignore. But I think the thing to bear in mind is that we're talking about short-term outcomes, and the comparison is an inactive treatment, if you like, a control group or a waiting list or whatever. And looking at the quality of the evidence, the reviewers concluded moderate certainty of these results, and they identified evidence of heterogeneity. So there's some issues with bias in the underlying evidence, and we can't do anything about that now retrospectively. So these are things we perhaps need to be a little bit cautious about. So my conclusion from reading this review was that it's a well-conducted review. It found some short-term benefits of TCBT in young people with anxiety disorders, but again, the comparison was doing nothing effectively, and we're perhaps not 100% clear what are the active ingredients in that TBC. What is it that makes the difference? Why are some things better than others? There is a bit of risk of bias in the underlying trials. We perhaps need to do more about the reporting of these studies to make sure that they're more methodologically reliable. And we need to gather evidence on longer term effects and potential adverse outcomes, none of which were looked at here. So that's my lightning review of Cervin et al.'s systematic review. I hope you found that useful, and back to the campfire chat. There you go, take that.
Thank you.
Hope that was enjoyable for everyone. A couple of questions about, might be worth highlighting. One for Matti is why we use odds ratios to combine all these results into one overall estimate. I thought I would land that one on you, if that's all right. Just to talk a little bit about that. And I just want to finish by saying, just echoing the comments from before, I think one of the key things here is that these types of intervention have changed so much over time. And are we looking at stuff done in 2008 and stuff done this year? Are these at all comparable? Certainly when we think about online learning, campfires are obviously a fantastic evolution, which we didn't have 5 years ago. So does that mean online learning is, you know, so there's, I'd also be interested, I noticed there's a couple of developers in the chat, people who are developing TCBT, as we're calling it today, and any suggestions they have about how, because there's a lot of work goes on behind the scenes in the human-computer interaction literature that might be able to shed some light on, these are the active ingredients, these are the principles, and these are the things that make a good application. So it's an area where I think we need a bit more, you know, crossover between healthcare, social care, education, and the computer science literature.
Okay, so let's tackle the odds ratio one first then, because I think that's a really important question, and it's something that comes up all the time. So this review generated an odds ratio of 4.7, I think it was, Matti. What on earth does that mean?
It's very hard to kind of get your head around. I would actually just compare it because it's not very advanced. We have 9 studies and they compare TCBT to a comparison treatment or intervention or arm. And then we have, because we look at this remission, so it's a binary outcome. Either you are in remission or you're not. And then odds ratios is a way to present the probability of being in that state in one arm versus another. But the better thing is to actually look at the pure remission rates. So we also did a meta-analysis of how many in each arm were in remission. And I'm trying to get the paper up. So then we can see that in TCBT after treatment, here it is, then 38% were in remission of their primary anxiety disorder. And I think in the comparison condition, I don't have it in my head, something like 7%. So that is the difference, I would say. That is the difference that you can kind of understand. So yeah. 4 out of 10 reach remission in TCBT and 1 out of 10 in the control conditions.
Okay, but just for people who want to understand odds ratios, so an odds anything over 1 is a good thing with an odds ratio, isn't it? And I suppose in this case, we're saying you're 5 times more likely to achieve remission of anxiety if you have the technology-based CBT versus the control, whatever that is.
Yeah, yeah.
So what would you say, Douglas, generally for these sorts of reviews? What would you say? What is a good odds ratio? What should we be aiming for, do you think, or is it not possible to do that?
Well, I mean, I think that's that's a substantial odds ratio. If you look at the context of other research that looks at any type of intervention, because normally we are only doing research because we're not sure, and we're only not sure because the effects are moderate. You know, they're not dramatic effects, and it wouldn't be ethical to do a lot of research into things that were like parachutes for skydiving. You wouldn't. There has to be that sort of narrow band of uncertainty where you're sort of ethically justified in doing a randomized trial. So generally, the kind of effects are not as big. The odds ratios tend not to be as large as that, which is kind of why that I felt that it's kind of too much. We can't just ignore this and say, it's we don't like the quality of evidence, or there's too much heterogeneity. It does look like there is some benefit for some people.
Yeah. So what are the clinical implications then, Maria, of this? I guess it's important that we remember that we're comparing computerized CBT with nothing, essentially, with waitlist or with control. So actually 5 times better than nothing. So it's not like we're comparing it to CBT face-to-face. A different odds ratio there would be, as good as face-to-face to CBT would be a great result. What would you say are the clinical implications? What should we be doing with this evidence?
So it's really interesting because we've already been having some of these conversations in the chat about how face-to-face compares to TCBT, and there is some evidence, but particularly in adults, that there's equivalence of outcomes for face-to-face and at least therapist-guided internet CBT. But of course, it differs hugely because of all the factors we've talked about already, all the differences between the studies and differences between what's on offer face-to-face. Too, I think the issues we've talked about today in relation to TCBT apply to face-to-face too. That, do you get 6 sessions or do you get 16 sessions? And is your therapist trained as a clinical psychologist or a specialist therapist, or are they more of a low intensity interventionist? I think, Andre, for me, the clinical implications also come back to the point you really opened us up with today, which is what works for whom. And I think the real answer is we really don't know yet. This review points in directions that are helpful. I think in particular, the hint Matti talked about that more therapist input is useful and leads to better outcomes is quite a consistent finding across all the reviews done in this space. I'm not entirely convinced that at least for people who are at the level where they've got an anxiety disorder diagnosis, that something that's entirely unguided is what they need. I think at much earlier stages of the journey, perhaps that is sufficient, and perhaps it's what some people want. But there is this hint in the literature. I think it's important too for us to really think about, are these interventions actually freely and openly available? Because I think that's a huge issue when it comes to clinical practice. So many of these things are great, but can I really get hold of them for the young people that I see in practice, whether I'm working in a school, whether I'm working in the NHS, whether I'm a GP? I hear the frustration so many times that, yes, that's great, that worked, but I've got to pay so much to use it, or it's not freely available, it's not in England yet. So I think the reality is it shows there's real promise, but we've got enormous work to do. And there was just a point made by Paula in the chat, which I think is incredibly important, is that we don't end up just lost in this digital pathway where young people get pushed from pillar to post without ever kind of getting to a place where they get the help. I think we really do need to improve, Andre, on having a no wrong door approach. Like, wherever someone comes and asks for help, we can help them to match with the help that suits what they're looking for and that fits with the best evidence we've got right now and what's available in our systems.
That's brilliant. Okay, well, let's delve into that in a bit more detail then. Before we do, let's put the third poll up for people. So this is asking you a bit more of an open-ended question. We're interested in your thoughts on how you keep people engaged with online CBT. So you might want to write this from the perspective of somebody who's tried it, or you might want to just think, I do face-to-face CBT, this is how I keep people engaged. How could that translate to an online setting? So that poll's going to remain open for the next 10 or 15 minutes. We're going to come back to the answers later. So think that through and type your thoughts into that as we go along. Whilst we do though, Yasmin, I'd like to bring you in again. And I suppose as we're starting to think about what works for whom, I'd like to kind of ask you what your thoughts are on how you think we should identify young people who are going to benefit most, or how young people are going to self-identify as someone who might find a digital approach useful for them.
Yeah,
Yeah, what are your thoughts on that?
I think so identifying young people who might need digital CBT or CBT. So for me, I think identification. I had TCBT when I had like a relapse with my anxiety. So I could already identify that I needed that support, but I didn't really require face-to-face like CBT as I had done before. So the self-guided CBT was fine with me. I've already been through that experience, but I don't know if somebody else who hasn't been diagnosed yet or is just starting to display symptoms, if they'll know what they need, or what type of CBT that they'll need. I think there's other like practical issues as well, like flexibility, where they can have the CBT, like their timetables, if they're students, if they might want digital or TCBT. Other things like well, who they live with, if they feel comfortable having TCBT in their like student apartment, or if they're a minor and living with their parents, they might not feel so comfortable doing digital CBT in a family space. So I think those are some of the things that need to be considered.
That's brilliant. Yeah, really, really great ideas. I think I really like the idea about the kind of relapse prevention approach, almost where you're taught how you do CBT and you learn it from somebody in person, but then you have this kind of top up, maybe guided or maybe digital or maybe unguided sort of way of returning to it and reminding yourself and working through it. I suppose you have to work out, first of all, that you've got anxiety. You know, many people live for many years not realizing that actually they have anxiety, and then when they do find it, finding the answer, finding the solution to it can take some time as well. But yeah, those are all really great suggestions. I'm interested, Matti, in your thoughts on what's happening in Sweden, because you know you're rolling this out in Sweden, and I guess this sort of you know digital approach is being rolled out in many countries. I'm not going to ask you if rolling it out is ahead of the evidence, because I think we've kind of discovered already that it probably is, although we've got some good evidence, it's emerging. I don't want to get into that conversation that we're doing something that we don't have evidence for, because that's just the way it always is in mental health. You know, 80% of what we do, there's no evidence for. But so the question I think is more around how we can ensure that the interventions reach the young people at the point in which they need it. What's your sense of how that's happening in Sweden?
So Sweden has been quite in the forefront of examining internet-delivered CBT from the adult side during like 20 years. And there's a lot of more studies on the adult side. And I saw someone in the chat had a very nice review on face-to-face versus internet-delivered CBT. And I think from the adult side, we have evidence showing that face-to-face and internet-delivered CBT seem to generate the same effects in these populations that have been used. And often it has not been in the psychiatric setting. But in Sweden, Sweden has been on the forefront, and also on the child side, a lot of studies coming out of Stockholm for anxiety disorders and OCD recently, a JAMA study showing that internet delivered CBT for OCD as a first stage in a stepped care treatment was equally effective as just getting in-person CBT, etc. So we're rolling it out very heavily in Sweden. And I think at my clinic, most of the adolescents there have been offered or received internet-delivered CBT. But none of the programs we have used have been the programs in these studies. So that's another problem. Again, can you say the question again, Andre? I forgot it in the middle of this.
I think that you've answered it, but I'm interested in how that then works at a population level. So how do the population get internet CBT? Are they referred to it through primary care? What's their way into the system?
Yeah, so in Sweden,
and then if it doesn't work, what do they get next? How does that step care process work?
In Sweden, we have young people can easily access internet delivered CBT because in Stockholm they have these digital units. So you can kind of self-refer from all over the country, and then you can get a dose of internet literacy CBT if they go through an assessment session, often digitally. So I think for Swedish children and adolescents, it's quite accessible, internet literacy. I think so. Of course, the big problem, or another big problem, is, like you said, like first really seeing I have a problem with anxiety. That is often a huge step. So before you can even get help. But then how we should integrate it into the care pathway in CAMS is another question for me, because working with kids with anxiety and other mental disorders, it's not like you have one problem, then that's over with. You often have relapses, or maybe just need to learn how to live with certain tendencies, etc. So a lot of kids I work with, we see them for years. So to me, as a clinician and as with regional responsibilities, how to integrate digital interventions into the overall care pathway is much more interesting in one sense than the odds ratio for TCBT versus nothing. And I think that is the new kind of wave of research I would like to see more on service delivery. So how should we allocate resources to young children with mental health problems? And what are the risks and benefits of different ways of doing that? Should we do it in a stepped care way, so everybody gets ICBT without therapist involvement? Or should we kind of select, okay, you have these problems, you get to see a therapist? And I don't know, we don't have those answers, because most of the clinical trials are often intervention A versus intervention B. Not, here is one way to do mental health work with kids, and here is another. What are the pros and benefits and risks with each? I'm very interested in how socioeconomic factors may affect how different interventions and service delivery models, their effects. So we have some evidence from the UK, I think, that coming from socioeconomic adversity may lead to that you kind of fall out of these stepped care programs. So you are in need of more treatment, but you're not getting it. So I'm interested in those questions a lot. How to deliver care in a broader sense to young people with mental health problems, and how should we allocate these limited resources we have? And of course, the promise with TCBT or internet CBT is probably to get it out to everybody without any therapist involvement, because that is the kind of societal, the social, the economical promise, because we have so many people in need of treatment, and we can never satisfy that need within the resources we have at the moment. So if people we have this increase in seeking treatment for mental health problems. So if that trend continues until everybody that has mental health problems seek care, we need to do something that is not dependent on human beings delivering treatment.
Yeah, absolutely.
Probably.
Yeah. Listening to that, Maria, what's your kind of reflection? If the same thing happened over here in the UK, what would be your concerns about rolling out ICBT in that way? And what do you think are the real strengths of that sort of approach?
Yeah, I mean, I think the key concerns for me echo what they do for a lot of people, which is just that it ends up being used as a blanket approach. And there are young people who, for whatever reason, and I think Yasmin made the point very well, can't access TCBT, whether it's because they don't have a space in which they are safe and sufficiently private to do so in the way they live in their environment, whether it's because they can't get a stable internet connection. You know, we know that what we don't want to end up doing is having something that is a blanket approach that hasn't got that flexibility in to allow for different people's needs and preferences. So I do think that's the real risk in rolling out anything like this, is that it's seen as cost saving. So it does away with some of the other things that are very, very important sources of support. I think too, another real risk in the rollout here, and we've touched on this earlier, Andre, is that the technology moves on so quickly. We're always running to catch up with the research. And I think, as you said, lots of what we end up doing in mental health isn't evidence-based. And I worry that this TCBT and rolling out digital interventions really just makes that even worse than it already is, because by the time we've got permission to and trialed today's technology, it's 5 years later and technology is in a different place. We haven't got great studies that include TikTok, because TikTok's a relatively new innovation. But by the time we have done the robust get funding, do RCTs for stuff on TikTok's no longer where it's at. So I think that's a real challenge. And I think we've got to be careful to make sure that we're evaluating in clever and sophisticated ways whether what we're offering is working and for whom, so that we can make sure that people are getting what they need.
But surely this is an opportunity. If we're rolling out ICBT across Sweden and we've got an intervention that is being rolled out for the population, surely that's an opportunity to do the study, as long as we're measuring outcomes, consistently across all the different people in that. Is that what you're doing, Matti? Are you doing a huge trial of this kind of ICBT rollout so that we know how effective it is?
Yeah, we will do a big trial here in southern Sweden, where we take the anxiety disorders, because it's a very heterogeneous group, and that is also a problem here. Like a 17-year-old with panic disorder and generalized anxiety disorder is not the same. They are not having the same problems as a 7-year-old with separation anxiety disorder. And I think the youth literature on CBT is lagging behind on how we can treat different kinds of problems at different developmental stages. So that is also a problem. But actually now we're planning and have received some funding to do a very big study on youth anxiety, where we randomize participants not to interventions, but to service delivery models. So we will randomize half to stepped care. And stepped care will be internet delivered CBT in the first step. And if you don't respond, you will be moved up to individualized in-person CBT with a lot of exposure, because that seems to be an important ingredient. And then the third step, and we don't know how many participants will not respond to either of these two, because those studies have not been done, we will offer medication and intensive CBT. And then the other half of the participants will be matched to intervention. So based on what we know currently about poor response to CBT, for example, having social anxiety disorder is a predictor of poor outcome of CBT, then we will probably stratify. So people who have a lot of red flags of poor response will be stratified to individualized in-person CBT. And then we will compare efficacy, so which service delivery model yields the best effects on remission and self-reported outcomes, quality of life. But we will also examine cost effectiveness from a societal perspective. So how much effect do we get per Swedish krona? But we will also see whether stuff like clinical complexity and severity and socioeconomic status moderates the effects in each service delivery model. So that is a very big study with 600 families we need to recruit to be able to do everything we want. So I will be doing that for 10 years probably.
Yeah, I was going to say,
we hope to learn a lot about treatment for anxiety in youth. But probably I haven't really thought about that before this session. Of course, the digital technology moves so fast. And all my kids at home, what they do, they text all the time, continuously. And probably that would be a very good intervention, kind of working with text-based, more continuous communication with patients. So I have my 8 working hours, and I maybe have 40 patients, and they can text me whenever I will answer my working hours. So yeah. I think that might be a more ecological way of doing this treatment, instead of these modules that is kind of non-flexible, like Maria said, module 1, this is anxiety, module 2, this is anxiety management, etc.
Yeah,
and of course, in 10 years' time, we'll have a lot of revolution, probably how you can use technology to help people with their everyday problems, including anxiety.
Yeah, ideally you want research that can actually adapt, don't you? So you can have interventions that work on different platforms. As Maria says, if a new social media platform comes along in 6 months, we just move on to that and we do the same thing that we have been doing. We're out of time, so I'm gonna have to draw this to a close. Thank you so much, everyone, for participating. To our panelists, to Matti and Maria and Yasmin, you've all been brilliant.
Find out more about becoming an ACAM member and to be part of the advancement of child and adolescent mental health, visit www.acamh.org.